Welcome back, everybody. Today we're doing a deep dive into ICD-10-CM coding,
No. Okay.
specifically for mental health and neurodevelopmental disorders.
Right.
Now, just imagine
Yeah.
you're a healthcare provider seeing all sorts of patients.
Right.
Anxiety, depression,
Mhm.
substance use, dementia.
Huh.
Getting those codes right.
Yeah.
It's not only vital for patient care,
Right.
but also for insurance claims.
Absolutely.
And to help us navigate all of this,
Okay.
we've got a fantastic resource.
Right.
The Absolute Medical Coding Institute's Medical Coding Guidelines, MCG Manual.
Okay.
It's linked down in the description.
Gotcha.
But for now,
Yeah.
let's just decode some of these complexities together.
Sounds good.
You know, it's fascinating.
Yeah.
There's even a code for pain exclusively related to psychological factors.
It's true.
Who knew?
It really highlights that connection between our mental and physical health.
Oh, definitely.
That code F45.41. That's when pain is mainly rooted in things like stress or anxiety, rather than a physical injury.
So like if someone's chronic back pain
Yeah.
is mainly triggered by stress,
Exactly.
that's when you'd use F45.41.
Yes, and that's distinct from F45.42,
Okay.
which is used when the pain has both
Both.
physical and psychological components.
Gotcha.
So getting this code right
Right.
can really impact a patient's treatment plan.
Makes sense?
Are they going to get therapy, pain meds, or both?
Uh-huh.
It could even impact insurance coverage.
Wow, that's a big difference
It is.
for just one digit in the code.
Huge difference.
And there's an excludes one note for F45.41, right?
Yes.
What is that?
That means you can't use it
Okay.
if you're also using a general pain code from the G89 category.
Okay, that makes sense.
Yep.
Now let's talk substance use disorders.
Okay.
These codes can be pretty tricky,
They can be.
especially those in remission codes.
Yeah.
Can you break those down for us?
Sure. The key is to understand the difference between substance abuse in remission and substance dependence in remission.
Okay.
Think of it like a spectrum.
Okay.
Abuse is on the milder end.
Right.
Dependence is more severe.
Gotcha.
The choice really depends on how severe that original substance use disorder was.
So if someone just had a mild issue with alcohol
Yeah.
and they've been sober for a while,
Uh-huh.
that would be substance abuse in remission.
Exactly.
Okay.
And if it was more severe,
Yeah.
then it would be substance dependence in remission.
Gotcha.
It hinges on the provider's documentation and their clinical judgment.
And there's a hierarchy, right?
Yes.
When documenting use, abuse, and dependence.
You got it.
Can you explain that hierarchy a little more?
If the documentation mentions both use and abuse,
Mm.
you code for abuse.
Yeah.
If it mentions abuse and dependence,
Right.
you code for dependence.
Okay.
And if all three are documented,
Okay.
dependence takes precedence.
So we're always coding for the most severe level documented.
Always.
Okay, so let's say a patient's record says they use and are dependent on cocaine.
Okay.
We'd code for cocaine dependence to
Exactly.
reflect the most accurate situation.
Right.
Now, what about those unspecified substance use codes?
Okay.
When do we use those?
Those are only used
Okay.
when the provider specifically documents unspecified substance use
Mhm.
and links it to another disorder or medical condition.
So it can't just be a catch-all.
No.
It has to be deliberately documented
Yes.
and connected to a specific health issue.
Exactly.
Got it.
Good.
Now, what if someone has a medical condition
Okay.
caused by substance use,
Okay.
like alcohol-induced pancreatitis?
Right.
Would that be coded as a substance-induced disorder?
You would think so,
Right.
but it's actually not.
Really?
You would assign a code for the medical condition,
Okay.
like K85.2 for alcohol-induced pancreatitis,
Right.
and a code for the substance use disorder, like F10.20 for alcohol dependence.
So we're coding the consequence and the cause separately.
You got it.
Interesting.
It ensures we're capturing both the medical issue and the underlying factor.
Okay.
It paints a clearer picture.
What about blood alcohol level?
Oh,
Does that get in the separate code?
yes.
Okay.
You use a code from category Y90,
Okay.
but only when a condition classified under F10,
Right.
which covers alcohol-related disorders,
Mhm.
is also documented by the provider.
Okay, so both are needed.
Yes. And it's worth noting
Yeah.
that anyone who's a clinician,
Okay.
not just the patient's provider,
Right.
can document blood alcohol level.
Oh, I could see how that would be really important,
It is.
especially in like emergency situations.
Absolutely.
Now, let's talk fictitious disorder.
Okay.
It's divided into
Yeah.
fictitious disorder imposed on self, Munchausen syndrome,
Mm-hmm.
and fictitious disorder imposed on another or Munchausen by proxy.
Right.
How do we code those?
For factitious disorder imposed on self,
Yeah.
you'd use a code from subcategory F68.1,
Okay.
but when it's imposed on another,
Right.
it gets more complicated.
Okay.
You would assign code F68 to the perpetrator,
Okay.
but for the victim,
Uh-huh.
you need a code from T74
Okay.
for confirmed abuse,
Gotcha.
or T76 for suspected abuse.
So we're coding for both the perpetrator and the victim,
Yes.
which really underscores the gravity of the situation
It does.
and the ethical and legal implications.
Absolutely.
Must be enormous.
They are.
Okay, before we wrap up this first part,
Yeah.
let's talk about dementia.
Okay.
Both the type and severity are important for coding, right?
Got it.
So how do we code for all that?
Dementia is classified by its cause,
Okay.
also known as etiology,
Right.
and its severity.
Gotcha.
Categories FO1, FO2, and FO3
Okay.
cover different causes. And within each of those,
Yeah.
you'll find codes for the severity.
So, like, how do we choose which severity code to use?
It should always be based on the provider's documentation,
Right.
but if it's not specific,
Uh-huh.
then we default to unspecified severity.
Okay.
Does that make sense?
It does.
Good.
What happens if a patient's dementia worsens during their hospital stay?
Okay.
Do we code for the initial severity or the highest?
You code for the highest severity documented.
During the entire stay.
Yes.
To make sure it reflects how the condition progressed,
Exactly.
even if it fluctuated.
Right.
That makes a lot of sense.
Good.
We've covered a lot of ground
We have.
just in this first part.
Yeah.
Who knew medical coding could be so intricate?
It's a whole world
It really is.
unto itself.
And we've only just scratched the surface.
We have.
Stay tuned, everyone.
Yes.
We'll be back soon with part 2
Okay.
of this deep dive into mental health and neurodevelopmental disorder coding.
Looking forward to it.
Welcome back to our deep dive
Oh, hi again.
into this fascinating world of mental health and neurodevelopmental disorder coding.
All right.
In the last part,
Uh-huh.
we talked about pain disorders,
We did.
substance use,
Right?
and even factitious disorder.
Yeah, that was a good one.
It's amazing
Yeah.
how much detail
Yeah.
goes into representing these conditions accurately
Right.
in medical records.
Like we're piecing together a puzzle,
Yeah, I like that.
making sure all the codes fit perfectly
Right.
to create this complete picture of the patient's status.
Exactly.
And that's what we're going to keep doing in this part
All right.
as we explore other important areas.
Okay, I'm ready to dive back in.
All right.
What are we unpacking today?
So today, let's focus on intellectual disabilities.
Okay.
These conditions,
Yeah.
they affect a person's cognitive abilities
Uh-huh.
and how they adapt to everyday life.
Right.
Coding them accurately
Right.
is really important.
Yeah, I would imagine so.
Because it directly impacts the support and services
Okay.
that individuals receive.
That makes sense.
Yeah.
So how do we even begin to code for something like that?
Well, the first step
Yeah.
is to understand the individual's level
Okay.
of intellectual functioning.
Gotcha.
This involves looking at things like IQ scores,
Okay.
adaptive behavior skills, and how these affect their daily life.
So it's pretty comprehensive.
It is.
It's not just about a test score.
Nope.
It sounds very personalized.
It is. It has to be.
Right.
So once you have a clear understanding,
Okay.
you can assign a code from the F70-F29 category, which covers a range of intellectual disabilities,
Okay.
from mild to profound.
Gotcha. So it's not like a one-size-fits-all.
No, not at all.
Okay.
The codes need to reflect the individual's challenges and their needs.
Makes sense.
And remember,
Yeah.
accurate coding has ripple effects.
Oh, no, so?
It impacts individual care, of course,
Right.
but it also contributes to research and advocacy efforts
Okay.
aimed at improving the lives of people with these disabilities.
It really highlights
Yes.
how these codes are more than just numbers
There's so much more.
on a page.
Yeah.
They have real-world implications
They do.
for individuals and for society.
Absolutely.
Okay.
Speaking of real-world implications,
Okay.
let's move on to autism spectrum disorder,
Okay.
or ASD.
ASD.
This has been getting a lot of attention lately,
It has.
and for good reason.
It's not called a spectrum for nothing.
Exactly.
Yeah.
Some people with ASD need very little support while others need much more. So how do we capture all that diversity
Right, exactly.
in the coding?
Yeah.
It's a two-step process.
Okay.
First, you identify ASD using codes from category F84.
Right.
Then you specify the severity level,
All right.
which ranges from level 1, needing support,
Okay.
to level 3, needing very substantial support.
So determining that level
Right.
must require a lot of observation,
It does.
a lot of assessment.
Yeah.
You have to consider
Okay.
their social communication challenges, the rigidity of their behaviors
Right.
and interests, and the overall impact on their daily functioning.
Okay. And I imagine we also use additional codes
We do.
to specify any like intellectual or language impairments
You gotta.
that often come along with ASD.
Yes, you would use codes
Okay.
from the F70, F79 category
Okay.
to indicate intellectual disabilities, and codes from F80
Okay.
for speech or language disorders.
So this layered approach
Yeah,
paints a more detailed picture
it does. Much more
of
nuanced.
the individual's needs.
Exactly. And by using these codes correctly,
Right.
we can help ensure
Yeah.
individuals with ASD get the right interventions
Okay.
and support they need.
And support to thrive.
To thrive, that's a good word.
It is.
Now let's talk about something that's often linked with ASD, attention deficit hyperactivity disorder,
Okay.
or ADHD.
ADHD.
I'm sure a lot of our listeners are familiar with this one,
Yeah.
either personally or through someone they know.
For sure.
How do we code for this one?
ADHD
Yeah.
is characterized by a pattern of inattention and or hyperactivity, impulsivity
Right.
that interferes with functioning and development.
Hmm.
The key to coding it correctly
Okay, what's the key?
is knowing the difference between the subtypes.
Okay, so can you elaborate on those subtypes?
Absolutely.
I know there's a few.
There's the predominantly inattentive presentation,
Okay.
the predominantly hyperactive impulsive presentation, and the combined presentation.
Right.
Each has specific codes
Okay.
within the F90 category.
Right.
For example,
Yeah.
F90.0
Right.
is used for ADHD, predominantly inattentive.
So the code we choose
Yeah,
depends on which symptoms
Yes.
are most prominent.
it does. And of
Okay.
course, we rely on the provider's documentation
Right.
when making these decisions.
Makes sense.
Yeah.
What happens if someone has both
Oh,
ADHD and ASD?
you code for both.
Okay.
It's not unusual for these to co-occur.
Yeah, that makes sense.
You would assign codes for both,
Okay.
reflecting the complex interplay of
Oh.
their symptoms.
Makes sense.
It's a good reminder
It is.
that these conditions don't exist in isolation.
Definitely not.
They often overlap and interact in really intricate ways,
Mhm.
and that's why accurate, detailed coding is so crucial.
It really is.
It helps us create
Yeah.
a comprehensive roadmap.
Right. Like a plan.
Yes, a
Yeah.
plan of their needs,
Okay.
leading to more effective
Mhm.
and personalized interventions.
Now, let's talk about eating disorders.
Okay.
These often involve
Right.
distorted body image,
Mm-hmm.
fear of gaining weight,
Yeah.
and disturbances in eating behaviors.
Big time.
How do we code for these?
Eating disorders. Yeah.
Are complex.
Right.
Their impact can be devastating.
Yeah, definitely.
The key to accurate coding
Okay. Tell me.
is to understand the criteria
Okay.
for each type of eating disorder.
Okay.
We need to capture both
Both.
their eating patterns and their thoughts and feelings
Okay.
about their body and weight.
Gotcha.
So can I walk you through some of the types
Yeah, please.
and their codes?
Yeah, let's do it.
So let's start with anorexia nervosa,
Okay.
characterized by restricting energy intake,
Mm-hmm.
leading to very low body weight.
Right.
There's also an intense fear
Right.
of gaining weight
Right.
and a disturbance
Mhm.
in how one perceives their
Yeah.
body.
Okay.
The codes for anorexia
Okay.
are in the F50 category.
Yeah.
For example,
Yeah.
F50.01
Okay.
is for the restricting type,
Right.
and F50.02
Okay.
is for the binge eating purging type.
So even within anorexia, we
Right.
have distinctions
Right?
based on behavior. Absolutely.
Okay.
Then we have bulimia nervosa,
Okay.
which involves recurrent episodes of binge eating,
Mhm.
followed by things like vomiting
Right.
or misusing laxatives
Okay.
to prevent weight gain.
Gotcha.
The code for bulimia is F50.2.
Okay, so it sounds like we need to document
We do.
both the eating patterns
Right.
and the thoughts and feelings
Absolutely.
about body and weight.
It's all connected.
Right.
And we can't forget
Oh, is there another one?
binge eating disorder,
Okay.
characterized by those binge eating episodes,
Mhm.
but
That's
without
about it.
the compensatory behaviors.
Okay, so like without purging.
Exactly.
Got it.
This is coded as F50.81.
Okay, so many nuances to consider.
There are.
It's clear that coding for this requires a lot of attention to detail.
It does.
And staying updated on the guidelines.
Very important.
Especially since our understanding of these is always evolving.
Always.
Now let's address personality disorders.
These involve enduring patterns of inner experience and behavior that deviate from cultural expectations, causing distress or impairment in various areas of life.
Okay, so how do we approach coding for these?
Personality disorders are challenging.
In what way?
Partly because of the stigma and partly because of the complexity of diagnosis. Relying on thorough clinical assessment is key.
Gotcha.
One that really takes into account their long-standing patterns of thinking, feeling, and behaving.
Okay, I believe there are different clusters or categories.
There are.
Personality disorders.
Yes.
Right.
The DSM-5 groups them into 3.
Okay.
Cluster A includes paranoid, schizoid, and schizotypal.
Right.
Cluster B includes antisocial, borderline, histrionic, and narcissistic.
Wow.
And cluster C includes avoidant, dependent, and obsessive compulsive.
Wow, so many different types.
There are...
Each with its own characteristics.
Right.
It's like a mystery.
It can be.
To find the right code.
Yeah.
Right.
Each has its own code.
Okay.
Within F60. For example, F60.0 is paranoid personality disorder, and F60.3 is avoidant.
So it's about finding that code that really reflects their patterns of personality.
Exactly.
Which requires a deep understanding of their experience.
Right.
And it's important to remember that these can co-occur.
They can.
With other mental health conditions.
Absolutely. In those cases, we would code for all the relevant diagnoses.
To capture the complexity of their situation.
Exactly.
Now, let's move on. To a topic that often needs immediate attention.
Right.
Suicidal ideation and behavior.
Right.
Accurate coding here can literally be a matter of life and death.
It can.
Right.
So how do we handle coding in these sensitive situations? Suicidal ideation and behavior demand a prompt intervention.
Of course.
And coding plays a vital role when coding for these issues. It's crucial.
What's crucial?
To differentiate between suicidal thoughts, plans, and attempts.
Gotcha.
Each represents a different level of risk and requires a different response.
So can you break those down for us?
Sure.
I imagine the line between thinking about it and actually doing it.
It can be blurry. Yeah. So suicidal ideation refers to thoughts about ending one's life. Plans involve formulating a method, and an attempt is any action taken with the intent of ending their life.
So the codes reflect.
They do.
The level of risk.
Yes, exactly. We use codes from R45 to document this.
Nice.
For instance, R45.851 is for suicidal ideation, and R45.5 is for a suicide attempt.
Gotcha.
If there's an immediate risk. Additional codes might be used to indicate emergency intervention or hospitalization.
So coding in these situations goes beyond just documentation.
It does.
It's ensuring they get the care they need.
Absolutely.
Now let's turn our attention to delirium, which is a disturbance in attention and awareness that develops over a short time and tends to fluctuate. So how do we code for this?
Yeah, especially given its unpredictable nature.
Delirium is a fascinating but complex syndrome. It can come from a lot of different things.
Like?
Medical illness, med side effects, substance use, or withdrawal.
Gotcha.
So when coding...
we need to document both its presence and the cause.
Right, to guide the treatment.
Exactly.
I imagine there are different types.
There are... the codes for delirium are in category F05. And they're further categorized by the cause. For example, F05.0 is delirium due to a medical condition, and F05.8 is delirium due to multiple causes.
So it's about connecting the dots.
It is understanding the full picture of what's contributing to the delirium.
And we need to be specific.
Yes.
about the severity, too.
Absolutely.
Which can range.
It can,
right.
from mild to severe.
Right.
We also note any features like agitation, hallucinations, or disorientation.
Wow. There's a lot to consider.
There is.
For accurate coding.
Yes.
It seems particularly crucial here.
It is.
With delirium.
Yeah.
Because it can have serious consequences.
It can have.
If it's not managed properly.
Absolutely.
Now let's explore psychotic disorders.
Okay.
These can manifest in many ways.
They can.
Including hallucinations,
right,
delusions, disorganized thinking, unusual behavior. How do we code for these?
Psychotic disorders can be incredibly challenging.
They can.
For individuals.
Right.
And those around them, accurate coding here
right.
really depends on understanding
the specific criteria.
The criteria for each type.
Yes. To make sure we're reflecting their unique experiences.
Okay, so can you walk us through some of the types?
Of course.
And their codes?
Let's start with schizophrenia.
Okay, yeah.
Characterized by a combination of positive symptoms.
Okay.
Like hallucinations and delusions and negative symptoms.
Right.
Like flat affect and social withdrawal.
Gotcha. So a lot going on.
There is the codes for schizophrenia.
Are found in F20.
Right.
And there are various subtypes
there are
of schizophrenia,
okay.
each with a unique presentation. For example, F20.0 is paranoid schizophrenia, and F20.1 is hebephrenic schizophrenia.
Wow.
Each subtype has characteristics that help us differentiate them.
What about schizoaffective disorder?
Okay.
And delusional disorder.
All right.
I know those can be tough.
They can
to distinguish from schizophrenia?
They can be tricky.
Yeah.
Schizoaffective disorder is coded as F25.
Okay.
And that's characterized by a combination of psychotic and mood symptoms.
Okay, gotcha.
And delusional disorder, characterized by one or more delusions, is coded as F22.
Okay, so we really have to pay attention to their symptoms to make sure we're using the most accurate code.
Exactly.
Okay.
It's also important to remember that coding for these disorders often involves capturing the phases of the illness.
Okay, like what kinds of phases?
Like acute episodes, partial remission, and full remission.
So we're not just coding for the type.
No.
But also their current state within that disorder.
Exactly.
It's capturing that dynamic nature.
It is a condition.
Okay.
Hey.
And of course, it's important to stay up to date.
On those guidelines.
On the guidelines.
Because our understanding of these is always evolving.
It is.
Now, let's shift gears, talk about anxiety disorders. These are often characterized by intense and persistent anxiety.
Yeah.
They can manifest in a lot of ways.
They can.
Including excessive worry, panic attacks, phobias, and obsessive-compulsive behaviors.
Absolutely.
So how do we navigate the coding for these?
Anxiety disorders.
Are really common.
They are.
And can have a big impact on quality of life.
Makes sense.
The key to coding.
Okay, what's the key?
Is understanding the criteria for each type.
Okay, like before.
To make sure we're capturing all those nuances of their experience.
So can you walk us through some of the types and their codes?
Okay, let's start with generalized anxiety disorder.
Okay.
Or GAD.
GAD, okay.
Characterized by excessive anxiety and worry about various things.
Okay.
GAD is coded as F41.1.
Right.
And how about panic disorder?
Panic disorder, okay.
Which involves those sudden panic attacks.
Right. Those can be really debilitating.
They can be.
Yeah.
Panic disorder is coded as F41.0.
Okay.
And social anxiety disorder, which is fear or anxiety in social situations, is F40.10.
Okay.
Each of these helps us pinpoint the specific challenge.
It's amazing.
It is.
That there's a code for each type. Allowing for such precise documentation.
Exactly.
And we have codes.
We do.
For specific phobias, too.
Yes.
Right.
Like agoraphobia, which is F40.00.
Right.
And specific phobia, which is F40.2.
So many different anxiety disorders.
There are.
Each with its own symptoms and challenges.
Right.
It's essential.
It is.
To rely on that clinical assessment.
Yes.
And the provider's documentation.
Right.
When assigning these codes.
To make sure. To make sure.
We have an accurate picture.
Right.
Of what's going on.
Now, what happens if someone has multiple anxiety disorders?
It's possible.
It is.
And it's not uncommon at all.
Wow. Really?
People can experience more than one type.
Okay.
In these cases, we would assign codes for all of them.
For all the relevant ones to create that overview of their anxiety experiences.
Right. So it's about acknowledging the full spectrum of their challenges.
Just exactly.
Not just focusing on one.
Not at all.
Right.
We want the full picture.
Okay.
And by using these codes correctly, we can ensure individuals get the right treatment and support.
Support, right.
They need to manage
their symptoms
and regain control of their lives.
It's about getting back in control.
This has been incredibly insightful.
It has been.
We've covered so much ground.
Right.
From intellectual disabilities to personality disorders to anxiety disorders.
Yeah.
It's amazing.
It is.
How each code has a story.
It does.
Behind it.
Representing real people.
Real people.
With real challenges.
It's true.
These codes are more than just numbers.
They are.
They represent the complexities of human experience. And by using them carefully, we contribute to better care.
Better care.
Better research and understanding of mental health.
Absolutely.
We've reached the end of part 2.
We have.
But don't worry.
No worries.
There's still more to come.
More to come.
We'll be back soon with part 3.
Okay.
Where we'll delve into even more fascinating areas.
Sounds good.
Of mental health and neurodevelopmental disorder coding.
Looking forward to it.
Welcome back, everyone, to the final part of our deep dive.
Hi again.
Into mental health and neurodevelopmental disorder coding.
All right.
We've explored a lot.
We have.
In the previous parts.
A wide range of conditions.
From childhood to those that affect us later. But there's still so much to uncover.
There is so much.
I'm excited for this last part.
Me too.
What do you want to dive into?
Well, in this last part, I want to get into some of the more intricate aspects of coding.
Right? Like what?
Like how we deal with cultural differences.
Oh, that's a good one.
And the fact that these diagnostic criteria,
they're always evolving.
It's so important to remember.
It is.
That mental health doesn't exist in a vacuum.
No, it doesn't.
It's influenced by our backgrounds.
Our cultures.
Societal norms.
Absolutely.
Even the language we use.
That's all connected.
To describe our experiences.
Yeah.
So how do we make sure
good question.
Our coding practices are sensitive to those nuances?
It starts with awareness.
Awareness, okay.
We have to be mindful of the person's cultural background.
Right, the individual we're coding for.
Exactly. Yeah. Understanding their beliefs, their values, how they express distress.
It's about listening.
It is.
And learning.
Absolutely.
It sounds like it requires a lot of empathy and stepping outside of our own perspectives.
Our own little bubbles.
Yeah, our own bubbles.
We also need to be aware of limitations of our diagnostic tools. Right, like the DSM-5.
The DSM-5, for example,
yeah,
is a product of Western medicine.
Right.
And it may not fully capture the nuances of mental health experiences.
In other cultures.
In other cultures, exactly.
That makes sense.
So how do we bridge that gap?
Right. How do we bridge that gap?
And make sure we're representing diverse experiences.
Accurately.
Accurately.
Yeah. I'm all ears.
One way is to use supplementary tools.
Okay.
Like cultural formulation interviews to gather more context.
About the person's experience.
Exactly. It helps us go beyond just those checklists.
Right.
And understand their story.
So it's about blending the standardized approaches with those personalized insights.
To get a more
complete picture.
Complete picture, yeah.
And sometimes someone's distress.
Right.
It might not fit.
It might not.
Neatly. Into a category.
We need to be comfortable with that.
Ambiguity.
With that ambiguity, yeah.
That can be challenging.
It can be.
Especially when we're striving for precision.
Right, we want to be precise.
In coding.
Yes.
But it sounds like flexibility is key.
Flexibility is key, absolutely.
And you mentioned that diagnostic criteria are always changing too.
They're always changing.
Mental health is such a dynamic field.
Very dynamic.
There's always new research.
New insights all the time.
So how do we keep up?
That's the question, isn't it?
And make sure our coding practices stay accurate.
Staying current is essential.
Essential.
We need to know the latest revisions to the DSM.
Right, and other manuals.
And we need to be reading the research.
The learning never ends.
It really doesn't.
In this field.
We're lifelong students.
We are
always learning.
Always refining our skills. And that's part of what makes it so fascinating.
So fascinating, yeah.
There's always more.
Always more.
To learn,
explore
more ways to improve how we understand and support
mental health.
Mental health, exactly.
Well, I think we've covered a lot in this deep dive.
It's been quite a journey.
It really has.
We've talked about accuracy,
nuance, cultural sensitivity.
Keeping up to date.
It's been amazing.
It has.
I feel like I have a whole new appreciation.
Oh, that's great.
For the role coding plays.
The role it plays, yeah.
And mental health care.
It's more than just
assigning
numbers.
It's about
communication.
Understanding. And ensuring people get the care. They need. It's like these codes are a bridge. Connecting parts of the healthcare system. Helping us speak the same language.
The same language, right?
When it comes to mental health.
Mental health, exactly.
And by using this language, carefully, thoughtfully,
and responsibly,
we
can make a real difference.
We can, a real difference.
In people's lives.
Absolutely.
Thank you so much.
Oh, you're welcome.
For sharing all of this with us.
It's been my pleasure.
And to our listeners.
Yes, to our listeners.
Thank you for joining us.
Thank you.
On this deep dive.
On this journey.
We encourage you. To explore those resources. Mentioned, including the MCG Manual.
Yes, the MCG Manual.
Link below.
To keep learning.
Keep learning, yeah.
About this.
Vital
aspect of mental health care.
Mental health is everyone's business. It really is.
The more we understand,
the
better equipped we are. To support ourselves. Our loved ones. And our communities.
Until next time.
Keep
those minds curious.
And those hearts open.